Okay, so hello everyone, and hope you're all looking forward to the shops opening and the hairdressers being back from tomorrow. Yay! Tonight I was asked to do a two-parter because originally we said hips and then we've added spine, and it's just about overall posture. I think there's a lot of talk at the moment about hip surgery. I think the Americans are doing a lot of hip surgery, but we have to think very carefully about hips and the whole relationship to posture. So this week we're going to do hips and look really quite closely at hips, adults and children. And then in 2 weeks, we'll look at spines and how it all fits together. Marnie's got a PowerPoint, which we're going to play. So let's stick the PowerPoint on and then there'll be plenty of time. It's not very long. So there'll be plenty of time for questions and discussion afterwards. So let's start. Okay, next slide, Marnie, please. So when we're thinking about posture, no part of the body can be treated as though it's not related. Head, spine, pelvis, legs, and even the arms all have an influence on posture. You can't just say, okay, one bit at a time. It doesn't work like that. If you've got pain in your hand, then you'll have your hand treated. But when it comes to posture, it's a total body thing. And although we're going to talk about hips tonight, we have to think that they're attached to the pelvis. They're part of the top of the leg and the pelvis attaches to the spine. So you can't really talk about the hips in isolation, although we're going to sort of work on that tonight. Next slide, Marnie, please. So this is the skeleton. Obviously, it's not the real thing. But as you can see, ideally, everything's in alignment. The head is straight. The sternum, the breastbone is straight, the ribs are straight, because that's a big issue in SMA, because it's not just the spine that twists, it's the ribs as well. The pelvis is straight and level, the hip joints, and that's what they look like, basically. I know that's just very schematic, but that is what they look like. And everything's in line. The center of gravity falls right between the feet when you're standing, and the arms hang symmetrically. Ladies are a bit different. Their pelvis is wider, their arms hang differently. Men are wide at the top and narrow, so they are an inverted triangle, whereas women are more triangular. But that's basically what a straight body looks like. Okay, next slide. So the issues that we have to think about when we're talking about hips and pelvis is firstly weakness and the effect of treatments on the weakness and also on posture and hips. Functional milestones, where you get to where you are type 1 before treatments. Are you a type 1 who's been on treatments a long time? So maybe a better type 1, a good type 2, a weak type 2, a type 3, ambulant still, non-ambulant, almost got back to ambulation, whatever. So where you arrived at functionally, obviously, is going to have a big effect on your posture because it's related to weakness. Hip development. Did your hips ever develop in the first place? And unless you walked or were a really good type 2, the likelihood is your hips never really developed properly. The muscles and the power in the muscles is not strictly what we're talking about with weakness, because what we need to look at very carefully is which are your strong muscles, which are your weak muscles, and how we separate those two and why that's so important. Obviously, contractures, posture, and equilibrium being in balance. And there are ways we can improve that, and there are ways we can't. Next slide. Now, one of the things we have to think about really is sitting, because that's what we do most of the time. All of us, even those of us who can walk, will spend the majority of our day sitting. Yes, you're in bed asleep at night, but that's not a functional position unless you are somebody who can't sit for very long and end up doing quite a lot of lying. But for the vast majority of us, sitting is the most usual position that we need, and therefore we have to think a lot about the sitting position, why it's good and why it's bad. Next slide. Okay, this is what normal hips and the pelvis look like, and this really is important to think about this picture and get this idea in your mind. Your pelvis is a ring, as you will know, and at the back it's much higher than at the front. Ladies and men have very different shaped pelvises. Even if you've never walked, your pelvis will be a different shape. And your hip joint, the ball of your hip, the femoral head, fits snugly into something called an acetabulum. It's a ball and socket joint that is the classic ball and socket in the body. It has a lot of movement, not everywhere. It shouldn't move everywhere. It doesn't move as much as the shoulders, but that's not the same sort of configuration. It is vaguely, but not the same. And the little insert picture shows you exactly what's going on inside the hip joint and how the bone fits in all those bits that are there. So that is a developed hip joint. That's an adult hip joint. You know that because it's sitting well inside the socket, but also the bones are all fused. And we know that in infants and children that your bones aren't completely fused at the growing ends until you stop growing. Next picture. So specifically with hips, we have to think about contractures, but you can have hypermobility, and that can be a bigger problem as sometimes as contractures. You can have subluxation, dislocation, dysplasia. We'll talk all about those. We'll talk a little bit about pain. I haven't made a big issue of pain, but obviously we can bring that up at the end. Whether that is affected by spinal surgery, which I think in a lot of cases it is. About surgery, positioning, bracing, or even splinting. Can we splint the hips? What effect does Botox have? Because I know some people do ask about Botox. The impact of or on standing, the increased power of hip flexors. Again, as I said, muscle imbalance is one of our biggest problems. And we have to think about the knees and the feet as well as the spine. How often do we monitor the hips? And when and if are we going to intervene? Okay, next slide. This is about standards of care. The second version of standards of care were published in 2018, but of course, when something is published in a year, it's probably been done at least the year before. So 2016, it's already 5 years ago now, and it wasn't common to intervene with hips, but the question now is that going to change? And we don't know. Some places are doing it, but we don't know the long-term outcomes. Next slide. So what are we looking for when we're looking at hips? What are the problems? Who are we going to consider? The very limited type 1 children who have major respiratory issues, we would never want to put them through hip surgery, and there's no value. The very good type 3 who is still ambulant, even if their hips aren't 100% symmetrical, are you going to stop them walking to do their hips, which may or may not help them? How often do we monitor? It really depends on growth. And if you're an adult, the likelihood of things changing is very little. But as some of you will know, your hips and certainly your spine can get worse. Things like sciatica can get worse as you get older. And up to a point, your posture and your shape can change just from repeatedly sitting in the same position. When to intervene? We still have to think about respiratory considerations, because obviously hips are quite a big operation, and not only are they a big operation, but if you're going to be in plaster afterwards, because some children will go into hip spikers, adults don't tend to be plastered. If you need a hip doing as an older teenager or adult, you will not go into plaster generally, but children do. We need to think about bone health. If you have extremely thin bones, actually, you can cause more harm than good, because anything that you try and fix may just crumble. And then what treatments are available? Is it a case of just releasing muscles, or does it need bony surgery? And bony surgery is not just one operation. There are several things that can be done. Next slide. Okay, now the position of the pelvis is so important. And in standing and sitting, even in lying. These are the three main positions of the pelvis. This is from the side. Obviously, the pelvis can be tipped up higher or lower in a front-on view, so that you may be tipped that way. But in terms of the hips, one of the biggest problems are these three positions. And the middle picture is spine neutral, which is what majority of us try and achieve. Not everybody does, not even if you're up and walking around and don't have SMA. You may have a little bit of extra tilt one way or the other. But this really causes a lot of difficulty. In the weakest children, what you normally get is this posterior pelvic tilt, and we'll talk about that a lot in terms of sitting, because when you have posterior pelvic tilt, and we've talked about this before, you end up in this kyphotic posture because you are being pulled back, as you can see. And when you're sitting, particularly if you're sitting on the floor or on a bed, you end up with this horrible posture where you can get quite a hump at the back. The opposite one is the anterior pelvic tilt, where your pelvis goes forwards, and the result is you overarch your spine, either to keep you sitting or standing. And basically in SMA, that is usually caused by tight hips. And tight hips, what tight hips do is they pull your pelvis forward, the muscles across the front of your hips pull your pelvis forward, and the way you get up is by overarching your back. Next picture. So this is posterior tilt in sitting, and if you imagine with your legs out straight, this is even worse. So this is why so many of you who come to GOS will know that the position that we really don't like for the weakest of children, it's fine for children who are relatively strong. When I say relatively strong, a good independent sitter, that's fine. But the children who are not good independent sitters, and that's usually the 1Bs, 1Cs, and some of the weaker type 2s, this is the position you end up in. And this hump that you can see in the spine is very, very hard to treat once it's there. Easier in adults, you can be braced and have your shoulders brought back, but we can see this is the Xbox posture, the mobile phone posture, and even if you don't have the posterior pelvic tilt, we're getting these awful kyphotic postures because of the way the children are spending all their time down here. When we were kids, everything was on a desk or on a table. Now everything's in your lap and everything's down here. And we are getting horrific postures. And in fact, we're getting this in teenagers generally, but I think in SMA, we're finding it in much younger children. And I think we're storing up a lot of problems for the future. Next slide. So what I've done is I've reproduced that picture of the pelvis because I want you to see where these muscles attach. And these are the important muscles. There are, because the hip joint moves in and out, ab and adduction, it moves backwards and forwards, flexion and extension, and it rotates internally and externally. There are an enormous number of muscles around the hip. And there are those muscles that come from the pelvis to the femur, the thigh bone, and there are those muscles that come from the pelvis all the way down to the knee. And there are those that go from the thigh across the knee. So you can have one joint muscles or two joint muscles. Two joint muscles tend to cause more problem. They're much harder to stretch because when you control one joint, something goes wrong at the next joint. What you have, and I've got easier pictures of that, but you can see from all this, the first picture on what's my left, it says superficial pelvic and thigh muscles of the right leg. So that's looking at the front at the right leg. And you can see that there's all sorts of muscles, and that mostly is your quadriceps. And that is flexes your hip, bends your hip, and straightens your knee. So it does basically all that. That's that one. The middle picture is the deep pelvic and thigh. And those are your adductors. Those are the ones that pull your leg inwards, and the ones at the back are often the ones that pull your leg out to the side and back behind you. And unfortunately, those in SMA are the ones that are weak, particularly that big body muscle, gluteus maximus, which isn't actually, there's bits of gluteus maximus on there, but they've actually cut it away so that you can see the muscles underneath. So those are the ones that are weak, and that's the problem. So you've got weak ones pulling your leg back, strong ones pulling your leg forward. And the other ones that are really important are the first picture, psoas major and iliacus, which together are called iliopsoas. And that's a really strong hip flexor. And that's very often the one that causes the contractures. So these are the muscles. So if we make a sort of simpler picture, next slide, Marion, please. Thank you for pointing all these out. That sort of shows you what's going on. You have gluteus maximus, and we've always said women have bigger bums than men because that's the muscle that gets you up and down the stairs and picks the dirty clothes up off the floor. So that's why ladies have big bottoms. So if there's any men watching, don't dare complain about a partner's big bum, because that's why they have them. Quadriceps are the muscles at the front. Hamstrings, the muscles at the back that everybody gets really in a tiz about getting tight, that is your strongest muscle group. And that does so much of the work, but it also causes a lot of the problems. That is the one that often pulls you when you're sitting into posterior pelvic tilt. So that's the one, it attaches to your bottom and comes all the way down past your knees. So it's a long muscle, not always a strong muscle, but it does get quite tight. And this is the one you measure by lying on your back and sticking your foot up in the air. We don't stretch hamstrings. They're such an important muscle at stabilizing your pelvis. We don't want them stretched, but on the other hand, they can get tight. They also get very asymmetrical if you have asymmetrical power, but it's a chicken and egg situation. They are tight because you are asymmetrical. They are tight because you're using them a lot, so they have to work really hard and be short, but they are asymmetrical because of the stronger side often has different tightness to the weaker side. Some people have stronger, tighter on the weak side. Some people have tighter on the stronger side, depends on the mechanics. But just stretching will not change the overall asymmetry. And that's another problem we have. Asymmetry is a big problem. Now there's a long white band down the outside of the leg. It's not muscle, it's fibrous tissue. That's your iliotibial band. Experiments have shown that it doesn't stretch very much in a normal adult male. If you strip out that band and hang weights on the end, it'll only stretch a centimetre or so. So trying to control it is difficult. Now what you can see is gluteus maximus and some of your hip flexors attaching to there. And if they are weak, again, what you end up doing is pulling out to the side, particularly when you're sitting with your legs wide apart. And that's for two reasons. Firstly, because it stabilizes the pelvis. And secondly, because the stronger muscles are helping to pull it that way. You can try and stretch it. If your physio is giving you stretches, good luck. My belief is with a piece of fibrous band, you're not going to stretch it very far. If you want to spend your day stretching a piece of string, that's fine, but you're not actually stretching the muscle. Next slide. Okay, baby hips. The normal hip joint is not developed at birth, and that's why so many babies get ultrasound. If you have a breech or you have a baby that's been lying in a strange position, they will always ultrasound the hips to see if they're in. And a normal hip will have a nice big round head, and it develops this neck of the femur. And you can see in the lower picture, the dysplastic joint, the neck of the femur is not necessarily well formed. It's the angle isn't right, and the head is particularly small. Once the head's small, the acetabulum doesn't form properly. Next slide. And this is what we end up with: a shallow hip joint, as you can see in the dislocation, or a not quite deep enough one in the subluxation. In the first one, you have a normal hip, but then you have what is called a dysplastic hip. Hip dysplasia is when the hip does not form properly. So you've got a normal hip sitting nicely inside the socket. You have a dysplastic hip that is not forming properly, a subluxed hip which partly comes out of joint, and these are often the ones that clunk, and you can feel them clunking in and out of the joint. They're subluxed, they're not completely out, but they're not completely in either. And a dislocated hip is one where it's never really formed a joint. Now, obviously, you can dislocate your hip in an accident, you can dislocate your hip in different ways. They can kind of fall out backwards, sideways, wherever. It's usual in a child with a dislocated hip for it to dislocate upwards, as you can see, so it becomes higher than it should be. But in an adult, it can dislocate forward. Classic example of hip dislocation are people who sit with their feet up on the car dashboard or with their knees bent up and get a bash if you have an accident and then your hip goes flying backwards. But there are other ways of dislocating hips. It takes quite a lot of force to dislocate an adult hip that's in a normal hip joint. But as you can see, if the hip joint has never formed properly, it's quite easy for it to dislocate. So what are they going to do if they do surgery on that? There's several things they can do. They can actually cut the thigh bone and change the angle of the thigh bone, or they can cut through the pelvis and re-angle the pelvis. But it is a lot of bony surgery. It takes a lot of screws and metal work, and it has to be held. And on top of that, they have to divide the muscles. They don't cut the muscles necessarily, but if anything's tight, they'd have to cut it because it would pull the surgery out. They try and what they call divide muscles. In other words, separate them and go in with the muscles moved apart. But if there's a lot of tight muscle, it's just going to pull their surgery to pieces. Then obviously they are going to release those muscles. Next slide. So going back to the whole concept of hips and posture, we have to think about the power around the trunk and the pelvis. We have to think about the symmetry all the way from the head being straight, the shoulders level, even the ears being level. Necks, we're fussy about looking at neck levels, shoulder levels, spine, whether the one shoulder comes round, whether your ribs are twisted, whether your ribs are bigger on one side at the front or the back. We always look at spines in forward bend, both in standing and sitting, if the children can stand, because it shows us sometimes you think the back is completely flat. When you lean forward, you can see the rotation of the ribs. Now, the way the ribs attach to the spine means that they're independent. So you can have a nice straight spine, but still some twisting of the ribs, or you can have a relatively twisty spine, but fairly straight symmetrical ribs. That doesn't often happen. Some people just have a little bit of twist. Some people have a major twist where the ribs really rotate and you get quite a nasty hump of rib, not spine, not kyphosis, but actual ribs. And you can't do anything about that. You cannot surgery it. You can't correct it. You can't start chopping ribs about. That's not going to do your lungs much good at all. Obviously, your hips and pelvis are a major factor in posture, but your spine is important as well. And there's lots of bits of your spine, as you know. Your thoracic spine can bend, but your lumbar spine is very mobile and that can bend and twist. And obviously your neck is part of your spine as well. The bottom part of your spine, your sacrum, is fairly fixed and rigid, and that's not going to twist, but everything can twist on that. And obviously the surface that you're on is going to affect how you sit. And you know that if you're comfortable, you can keep still for a while, and if you're not comfortable, you'll wiggle for ages. And those of us who have to sit on horrible seats in theatres or classrooms or wherever will know that you will wriggle more if you're not on a comfortable surface. Next slide. Okay, now patterns of weakness are really important. This is what we were saying. So the muscles at the front that bend your hips are the strongest muscles around your pelvis and hips, so that they will bend them up, and the muscles that pull them back will never be as effective. Now, we have seen that a lot with the new treatments. For the children who have gained a lot of improvement, some of them have got really nice strong hips that can do that, but can't do that. And we've got some children who can lie down and stick their legs up in the air and do wonderful, wonderful things. But as soon as you try and stand them up, they are so bent at the hips that we can't get them straight. So if you are stuck at about 30 to 40 degrees, it is very hard then to stand up without over straightening your back, and that's really not comfortable at all. Some of the children are so bent that it is painful, and very often to bring your body into alignment, what you end up doing is bending your knees to compensate, and so you end up in this sort of posture to bring your weight bearing into alignment, this bendy posture, and that affects your knees as well. So when you end up standing in a standing frame or standing wheelchair or wherever you're standing, you're ending up in this sort of bent posture. And that's where we go. And then there's pressure on your knees, pressure on your bum, pressure on your hips. But that is the main cause of it, is the tightness there. And this really is what stretching is all about. This is why sitting is such a problem, because what we end up is that it's very hard to control it. And there are so many parents out there who've worked extremely hard at trying to keep their children's hips from getting tight, and they still get tight. If you are hypermobile, you're at an advantage. It's obviously true if you're a bit lax and bendy, but children can get tighter as they get bigger, and they can definitely get tighter with the new treatments, is one of the problems. So we've talked about muscle imbalance before, but at the hips and around the pelvis, it's a really big problem because there's so many different ways you can be out of balance. You can be out of balance sideways at the spine, and that's going to affect how you balance on one body cheek. You can be pulled to one side so that you're sitting, and so many of you know that feeling where the children are basically sitting totally on one bottom cheek and hardly at all on the other. And in fact, a lot of you adults will be doing the same. And even when you have spinal surgery, you may well not correct completely. And for those of you whose spinal surgery does not go into the pelvis, usually the stronger children and the type 3s, they don't go into the pelvis. It doesn't alter the way you tend to sit on your pelvis because they haven't fixed you completely. Big problems when we have our spines then fixed, because what's happened is you've spent so many years sitting on one bottom cheek, and then suddenly everything's changed. And there is a picture of that. But again, with the magic rods, hopefully those are the sorts of things we're going to be able to avoid. But I know with COVID and with the problems that they were having with the magic rods, things have got a little bit difficult. Now, with the muscle imbalance, you can have muscle imbalance in several ways. First, obviously, is the fact that the hip flexors are stronger than the hip extensors. The hip outs and ins are both particularly weak, and the rotators are both particularly strong, although outward rotation, sticking your feet outwards, tends to be a bit stronger than rolling your legs inwards. So we tend to be out and bent, and that's where we end up with our knees bent in that sort of froggy sitting position. Those are the stronger movements. So although they're the stronger movements, you can still be stronger right and left, so that you can have the muscle imbalance on one side down to the other. And you can also have it in terms of higher up and lower down. So the body's in balance. We have stronger muscles and weaker muscles. Some of our higher up muscles are much weaker than our lower down muscles. Obviously, our leg muscles have to carry us about, so they generally are weaker. But as we know from the treatments, we have seen children who've done amazing things with their arms with the treatment and their legs don't move at all. And we've seen children who've done amazing things with their legs and their arms don't move at all. So there is no new natural history. We can't say that we know what any one child is going to do on these new treatments. Same for the adults, even more so for the adults, because with the adults, it'll be very much with the risdiplam where you started as to where you could possibly end up. If you're very contracted, you're going to have less result, but that doesn't mean no result, because one of the major issues for adults is not so much what you gain, but what you don't lose. Now, the other thing about the therapies, obviously, some children who got the gene therapy or the nusinersen or risdiplam very early are doing very well. I know a lot of parents are saying, oh yeah, the gene therapies are fantastic, that you've got to have it, everybody. Don't be persuaded too much by other parents, because most of the children on gene therapy, apart from the pre-symptomatic, are now on other treatments as well. So although the gene therapy has been incredible, there are still a lot of children who had gene therapy who are either on nusinersen or risdiplam. So it's not a cure. Unless you are pre-symptomatic, you are not going to find that everything in the garden is blooming. But hips remain our biggest problem, as I know several mummies out there will tell you. Okay, next slide. We know what asymmetry looks like. You can see from the red line that's supposed to be in the middle, everything gets skew if. The more you lean to one side, the more your head goes, the more your shoulders go, the more your neck goes. Even your arms will be affected, because effectively, if you're leaning, you end up propping. If your head's to one side, you end up with your hand here, so that in effect, you've lost a hand. And it becomes quite difficult to be asymmetrical. But if you look at the pelvis, and we have other pictures, you will know that you'll end up sitting more on one side. You can see everything there is asymmetrical, including the hips, although the knees and feet do look as though they're sort of in line, which is a bit strange. Because in that situation, even as one hip is higher than the other, the knees wouldn't be quite as symmetrical in there. Your hand dominance, even something like that, the side that you drive your wheelchair. Now, there are studies that say there is no relationship between the way you sit and the way you drive your wheelchair. But a lot of parents do know that the child will lean towards the side that they drive. Occasionally the child will lean away, but the vast majority of children do lean towards the side that their hand control is on. And that's why originally there used to be so many hand controls in the middle. The original Turbo had the controls in the middle, and several of the others either had them on a table in the middle or in a central control, which actually made it much harder to get them in and out, but supposedly kept them a bit straighter for longer. If your hips are out of joint, or one hip is out of joint, or one hip is out of joint more than the other is out of joint, it in effect makes your legs different lengths. And that can be quite obvious sitting in the wheelchair, that one will go out to the side or one will look further back than the other, which obviously then has a knock-on effect on your feet. But if one hip is dislocated and one subluxed, or one subluxed and one in, then you will have an asymmetry of your pelvis, an asymmetry of your legs and knees. A lot of you will notice that one knee sticks further forward than the other, is because it's rare for both hips to look the same. Usually one will look slightly worse than the other. Next slide. Okay, so this is what we tend to see in sitting, that you sit more on one bum cheek than the other, you're tipped to one side, your spine goes, your ribs are asymmetrical, your shoulders are, and the head looks straight in the middle, because we have this very strange tendency, whichever way our body goes, to correct our head to midline if we can. So that what you tend to do is, if somebody pulls you to one side, you automatically, right, if I'm pulled to the side, I don't tend to let my head go off to the side with me. I keep it in the middle. So I'll do this to counter. And that's very often what happens. And this is why we get neck problems as well when you're sitting on one bum cheek. Now, if you imagine that pelvis and keep that pelvis in that position, but straighten the spine up, and you're still sitting more on one bum cheek, or you are pushed over to the other bum cheek because your spine is straighter, obviously that alignment is something that you're not used to. If you've been sitting, if you're about 12 when you have your spinal surgery and suddenly everybody changes everything that's developed over 10 or 12 years, literally overnight, everything is changed, then you can understand why you get hip pain and hip problems. Certainly at GOS, most of the orthopedic surgeons will say that if you get hip pain, you can expect that for up to a year post spinal surgery. Some are very severe, we know that. Some start off severe, but do improve over time. But there are certainly some children who suffer a lot with post-operative hip pain that really does need some management. We've had steroid injections, we've had more surgery, we've had hip releases. We've had one young lady who's recently had quite marked hip surgery because she was actually arthritic in her hips, partly because of the change in position had caused rubbing of the joint in the socket. So the ball and socket were no longer sitting and moving in the same way. So she had a joint that wasn't good, but when she changed her weight bearing after spinal surgery, it sort of put it out of alignment. It's a bit like when you change your shoes and you find that you're walking on a different part of your ankle and you tend to ache for a little while. Same idea, you're throwing your hips out, you can get some quite marked pain from the change in position. Next slide. Now, obviously the surface has an influence on how you are, whether it's a hard surface, a soft surface, and that includes beds as well as seats. Is it soft? Is it squishy? Is it easier to turn on? Very often when the children come for assessment, they can roll on our plinths where they can't roll in bed because the mattresses are too squishy. If you've got one of the air type cushions or the tea bag cushions or gel cushions, that's going to be completely different to sit on to one of the more rigid type cushions. It really depends on your wheelchair service, on what you need, what you get. But the surface really does make a difference to your posture. Is it a flat cushion? Is it basic, just pretty much no contouring at all? Or is it quite markedly contoured? Does it have that big dip at the back? Does it have a little hump in the middle, which we don't particularly like being big, but as long as it doesn't push your legs out? Does it have dips for your thighs, or are they just the sort of scoop at the back? So there's lots of different shapes of cushion. Do you find it comfortable? Some people will say hard is better, the same with mattresses. Some will say it's softer better, but it's how long is it comfortable for? Is it fine for an hour, but then you're starting to get a numb bum? Do you need gel layers? Do you find that the gel squishes after a while and it doesn't help? Or is it custom made? Or is it just sort of off the shelf, stuck together, whatever? And how often, and this is adults as well, in theory, your cushion should be checked every year to make sure that it's still appropriate for your needs. Do you ever check the gel pads? Do you ever take the top off and see what's going on under there? Because it's quite a revelation to actually get inside your cushion and find out what's going on. Because there are many situations whereby you will need your cushion changing and make quite a big difference to how well you are sitting. Not only that, but a too long cushion or a too short cushion can have a really bad effect on your hips, particularly if your legs are too long, you're sitting in a position whereby your knees are up because your legs are too long on the foot plates, so that you're not supported under your thighs. And for comfort in sitting, the cushion should completely be under your thighs, completely in contact with your thighs. If it's not, your legs are too long, basically your knees are up, all the pressure is going through your hip joints. So cushions, seating position, your foot position is really important for comfort in sitting. Next. How do we manage hips? Obviously we do stretches, but people will say, well, they've stretched and stretched and stretched and they still get tight. We know that. We know that when you're sitting for many hours a day, a couple of stretches is not going to make a difference, but at least it's better than nothing. Positioning is so important, but it's really difficult if you're sat at a computer all day to be standing or lying. Exercise doesn't help that much. It's very hard if you've got really strong hip flexors and very weak hip extensors to exercise those muscles. What we've got to try and avoid is the machines and the systems and the elastic band spider webs that continue to exercise these muscles at the front and just make them tighter and tighter. And we know even with the machines that you are supposedly doing this, the question is how much work is actually being done here. I am not convinced that in those machines, and let's get real, they are not step exercises, because in a step exercise, you come into extension. If any of you go to the gym and use a step exerciser, you should be coming right into extension, whereas these machines never bring you right into extension, although they could be set up to do so. And the question is, can we splint hips? And we will have a look at that. Okay, so these are the stretches for adults. Next slide. Right, so sometimes you will get an adult who is quite comfortable hanging over the edge of a bed or a plinth and having this sort of what we call supine stretch. But to be honest, for the majority of adults, that is not going to work, because you will have such tight hips that the leg that goes up to flatten your pelvis actually is as uncomfortable as the one that you're trying to squash downwards. And again, these are passive, so that unless you are helping to bring down the thigh that is being stretched, so in this picture, it's the right thigh is being stretched, the left one is bent up to flatten the lordosis. Now, if you've already had spinal surgery, that's not really going to flatten, or it might already be flat, but it's really quite difficult for some adults to tolerate this position. And so the picture below is side lying, and that's often the easiest position for adults to have a hip stretch. It puts less stress on the spine, it puts less stress on the hip. You really do need to find somebody to help you who can stabilize your pelvis, because that's the problem. You really do need to have your pelvis stabilized, and then your legs taken backwards, your top legs taken backwards. But for adults, I think this is probably the most comfortable stretch. Now, the stretch with a lady with the knees up is the sciatic stretch. If you have sciatic pain, it is no good doing the supine stretch, because actually it's just going to further aggravate the sciatic nerve. And if you have sciatic nerve pain, you should be doing the side lying stretch, because you are less likely to aggravate the sciatic nerve. And if you have sciatic nerve pain, this is what you should be doing. If it's only one side, then you may find relief from one leg up. If it's both sides, then both legs up. But what you're trying to do is put as much stretch on the spine as possible. You can imagine in the supine stretch, the one leg up, one leg down, you are trying to bring the pelvis this way, whereas actually in sciatic nerve pain, what you want to do is bring the pelvis this way and really stretch across the back of the back as much as you can. Even with spinal surgery, you will find that the knees bent up is the best way to relieve sciatic nerve pain. What you may find is that you can do that better in side lying. And in that position, when you're lying on your back with your knees up, what you may find is if the person rolls your pelvis side to side or away from the side of the pain, that will help. So if you have right sciatic nerve pain, knees bent up, stretch over towards the left, not too much, but that will help to relieve your sciatic nerve pain. Next slide. Stretches for infants definitely should be done in supine. It's one leg up, one leg down. We give out this stretch. We say every time there's a nappy change, apart from the middle of the night, they should be doing one leg up, one leg down. So it's with nappy changes, so you don't have to remember to do it other times. You may have a child who doesn't have their nappy change very often, or one that has it done a lot. Well, that's the way it works sometimes. But if you remember to do this good stretch every time, because hip flexion contractures are there from very, very young, unless the child is lax. And with a good physiotherapy assessment, you should have been told if your child's got lax hips. Next slide. For children, we tend to use this position as well. We don't use prone anymore as a position for stretching, not for this sort of active stretch. And we suggest putting a squishy toy, probably not a balloon if children are worried about squashing it. We do talk about putting the cat or the dog or even a brother or sister in there. But the squash down should be under the thigh. If you ask them to push their foot down, beware that they're not just pointing their toe and ending up toes down, which is not what we want. What we want is the thigh being squashed downwards to extend the hip. So we want active extension of the hip, not pointy toes down. Next slide. Okay, so exercise is difficult, not impossible. Of course, swimming is always the best exercise, but we haven't been doing a lot of that recently. Again, I think pools are opening soon, so hopefully we can get back in. Hot tubs will be coming out again, so let's get some exercises done in the hot tub. Standing, swimming, you name it, it's actually good exercise. Again, you need to make sure that these are the muscles or these are the muscles, not the ones at the front that are doing the work. If you're not sure, ask your neuromuscular service. If you don't have one, find somebody who you can ask, any physio, to get some exercises in the water, because I think a lot of people have got hot tubs now or can go swimming. And if not, try the bath. If not, then we need to do some exercises with the TheraBand. You can do it inside lying. If you've got the bands and you've got been strung up with your arms, try it with your legs going backwards. All sorts of things that you can do. Don't say you can't exercise. You know, I don't agree with that one. Next one. Nobody's too weak to exercise. There are muscles that are completely switched off, I accept, but there are muscles that aren't. It doesn't matter if you're completely contracted, you will have some movement somewhere. You just have to know which muscles you want to exercise and not keep exercising the strongest one the whole time. Sometimes tape will help you just to understand which muscles you're trying to switch on, not because the tape will make a big difference to the movement or the power, but it will help you feel where you need to switch those muscles on. Next slide. Let's go back to this one again. So we're trying to strengthen the glutei, we're trying to strengthen the quadriceps. Those are the two that need strengthening, but we need quadriceps to be working as a knee extensor. In other words, we want the end of quadriceps, this part of quadriceps, which straightens the knee, to be working more than the end which bends the hip. So when we're talking about strengthening quadriceps, we're talking about doing lots of knee exercises, not lots of hip up exercises. If we can, legs apart. If we can't do it in lying or standing, then we can do static abduction You can be sitting with your legs with the bands, cross both legs and trying to pull them out. Even, as I say, static exercise, lots of work, no movement is fantastic exercise. Next one. Can we splint hips? Okay, so the top one with the baby is what you will get when a baby has naturally dislocated hips. And if that is found in SMA, probably even before the SMA is found, then you will find that the children end up in this sort of splint and can spend up to 3 months with their legs out, which is fine in a normal dislocated hip, but in a child who's weak, the question then is, are they then stuck in this position, and do we have to stretch them back into the middle? And that can be a problem. And this is a problem with surgery. And this is what we're concerned about, that a child who is put into this position post-surgery, then can we bring them back to the middle? And we have seen cases, not so much in SMA, more in CMD, but we have seen cases where children have got beautiful hips, but can't bring their legs back together and can't get them straight. Now, the picture below is a hip abduction brace, but it does make me wonder if something like this for in bed at night, where the hip is locked, wouldn't be possible. But what we have to think of is by the time the child or the adult has their BiPAP and maybe foot splints and all the other things going on in bed, do you want hip splints as well? Detraction is an interesting one, and I know that looks very strange. It's a picture of traction, which used to be associated with broken legs, and it wasn't until I was looking at splinting at the hips that I saw this. And when I used to work many years ago in juvenile arthritis, and I don't even know if they still do it, we used to have the kids tractioned in bed at night to preserve their hip joints. And the question that we maybe need to think about is, could we actually make a difference by tractioning the legs at night and stretching them out that way? And it is something that we maybe need to go back to. You've all seen something like the pink thing, the HCAFO, which some of the children stand in. It only works in certain children. It's not for everybody. It doesn't do that much. It's basically a glorified individual standing frame. So we don't advocate them in many children. I know that in Poland and in Italy, all the kids have these, but as I say, in a lot of cases, it's just a glorified standing frame, and we prefer the kids in CAFOs and always have, so that they're doing more work. And the black and white picture, if you really want to see splinting, is what is known as a gauche brace. These are what they used to do at this French hospital. I think I might have mentioned these before. And that is neck to feet bracing all day. And the kids spent all day in this. And I do mean all day. They didn't sit, they stood in these. They were in special standing frames like supine standers and spent their days in these. And then when they got to about 12 or 13, off it would all come, and they had spinal surgery and they were all beautifully straight, which was a lovely idea, but a strange way to spend your life. Hopefully, with magic rods, we may get away from this, but we still have the hip flexion contractures. So maybe the gauche people didn't have it completely wrong. Next slide. Okay, so we need to think about all these positions. We need to think about lying. What do we do? Do we use night positioning? Now, there is something in cerebral palsy called 24-hour postural care. We are not big fans of that in neuromuscular because we believe when the kids are lying down, it's not their biggest problem. We don't at Gosh, and we never did at Hammersmith 24-hour jackets, 23 as it happens. But I know a lot of people do. So there's a lot of difference of opinion of what you do when you're lying down, but there is a case for getting the kids into the best possible position without actually stopping them moving altogether. The biggest problem I have with sleep systems is it's great if the children are comfortable all night, but what we find is if the children need repositioning and they don't have carers, then mum or dad is not only getting up to turn them in the night, but having to reposition the sleep system, which can take 15-20 minutes, which is no fun when you're up 2 or 3 times in the middle of the night. We have floor sitting or long sitting on a bed, which we're trying to avoid in the smallest of children. So parents, if we've asked you to get them off the floor and you keep insisting, then don't come back to us when they've got a horrible kyphosis, that curvy back posture, and say, look at that horrible position, because it is caused by floor sitting, undoubtedly. And you can correct it even just by putting a little cushion under their bum, or a little block, or a little step, or a decent little chair. Chair sitting is great, except it means your hips and knees are bent all the time, which is why people sit on the floor, but your hips are still bent all the time. And obviously the straightest position is standing if you're not in lying. Next slide. Okay, so these are the floor sitter type things. They're Velcro and you can do all sorts of things with them, but you can see the children have to lean forward if they're weak, and this causes that kyphotic position. Very froggy, this child, can't get their legs out straight, which may work for hips, but actually for our kids ends up sticking them in that position, which we don't like. The other thing that is horrible about this position, those little floor sitters, is look at the position of the feet. It twists the feet in. So there's a lot that is fine for children with certain conditions, but we don't like it for weak children. We'd rather have something pretty ugly like the green thing, unless you like lime green. But a decent seat, it doesn't have to be like that. It can be anything that gets the child off the floor. Okay, 4 standing frames. The one we like best for the weakest children is what we call the supine stander. That's the first one, the blue one, which is where you start lying down and then you come up to standing. And that is the supine stander, and that is the best thing, nice and straight. You can position the children really well, but it is definitely for the weakest children. Once they gain some strength, then they should be in the next one along, which is an upright stander. Now that's pretty primitive looking, but it does the job. The one at the bottom with the baby in, we don't like at all. That's a prone stander. And you can see how much work they're doing with their head, which is extremely fatiguing, but also the bum sticking out, because they often do. And they're not fully weight bearing because they're actually taking a lot of weight through the front of their chest and their tummy, and their feet are not taking the weight that we would like, which will help them to get as straight as we would want them. They're fine for cerebral palsy, but it's not something we like in SMA. Now, a lot of the prone standers will go completely straight, and that's fine if your child is standing completely straight, absolutely fine. But we don't like them angled like this. It's a lot of work to keep the head up, and it's not weight bearing, so they're not standing with all the weight going through their feet. And the stander we like best for the children who can push wheels is the dynamic stander, which allows the children to get a bit of exercise while they're standing up as well. Now, the lying down things are 2 examples of what we call E-rolls to keep the legs in a nice position at night. Obviously, if you have hip flexion contractures, then your hips are going to stick up. If you have knee flexion contractures, your knees and hips are going to stick up. But if they roll outwards or tend to bend into a froggy position, they're quite nice pieces of equipment. My personal preference is the lower one. They're both made by a company called Match Supports, which is M-A-T-C-H, like match, E-double-T, Match Supports. And your OT should be able to get them for you. And that's, as you can see from the pictures, adults as well as children, because they can be custom made. Next slide. Surgery. Big thing. Are we going to start doing hip surgery? Well, certainly, if it's necessary, we're going to do it. But I was very worried when we had some parents who came to us, having been in the States, and that, oh, the doctor says we'll have to do her hips at some point. We took a hip x-ray and there was nothing wrong with the hips. The hips were actually really nice, according to our hip surgeon. But the American surgeon said, well, we'll have to have a look at them every year. Fine, we agree with that. But to tell parents they will have to have hip surgery at some time, I think is really not useful, because it may well be that she doesn't need hip surgery. Or it may be that by doing hip surgery, we end up doing more harm than good in a child who is standing really well. We don't know. So we don't know what surgery a child may need at this point in time. We don't know who is going to benefit from surgery. We don't have enough evidence. What about the recovery process? How much physio are you going to get in this country post-op? So that there is a lot of onus back on parents to do all this post-op management, lots of lying, lots of standing, and not lots of sitting. How long may they be in plaster? And if they're in plaster for 3 months, which is not unusual, are we going to lose a lot of ground in terms of standing and power? Will we be able to get the legs back together if they've been stuck out for a long time? What effect does this then have on the knees, the feet, and the spine? We haven't got to forget that. Is every centre able to do SMA? Obviously, they need to have the facilities not only for the hip surgery, but also for the post-op management. And again, we are back to the same idea that surgery is a treatment, not a cure. There'll still be muscle imbalance. There will still be issues that won't go away. And that as the child grows, we have to think it's not just about what we do with hip surgery at 3, 4, 5, 6. It's what happens when the child's 12, when they then become an adult. So we don't know the long term. There is a group, hip surgeries in SMA, which you can have a look at or join if you're interested, but we still don't have enough evidence of what surgery for what child at what stage and the outcomes. Okay, that's it. Next slide is all about questions. And I know we've got a couple. So hopefully we've got half an hour now for some questions, Marnie.
Yeah, we've actually got quite a few now. We've had quite a lot of questions come through. So the first question is, I'm having a lot of pain in my left hip. I have to go for an X-ray this week. Any ideas what might be causing it and what can be done to stop the pain? They then,
okay.
They added on afterwards that their hip hurts more when they're laid on their back and they can't straighten it as far as they usually can.
Okay, now there's 2 questions on there. Is this an older person who could have an arthritic hip? Do we know if the hip is dislocated or subluxed? I mean, I'm assuming this is an adult because they've said my hip.
Yeah, it is an adult.
And an adult who's had spinal surgery and what their spine looks like. Because adults with spinal surgery, we know wouldn't have had magic rods. They weren't around then. So it would have been a 1-stage surgery, and very often, one of the problems with spinal surgery is if you have a very mobile spine, you can get good correction. But if you have a very twisted or tight spine, then you can have a rod to stop it getting worse, but it won't necessarily straighten you up. Now, there are several reasons you can be getting hip pain. One is the hip can be arthritic, and that seems to be a big problem in adults. So if you think that prior to spinal surgery, you are sitting, your hips developed in a particular way, possibly not well, but you were sitting on one hip or you were sitting asymmetrically, spinal surgery has changed everything, which would have changed the articulation of the joint and how it moved, how the weight bearing changed. And over time, what you may end up with is an arthritic hip. That arthritis of a joint is basically wear and tear. We're not talking about inflammatory arthritis. We're talking about basic wear and tear that most people will get when they get older. There are very, very few people. I don't know if there's a female, Marnie, but women are more prone to these sorts of arthritises for whatever reason than men. Men tend to get arthritis more in joints if they've had particular sports. Rugby players, football players get a lot of ankle arthritis. But generally, women tend to get more arthritis than men. They become more osteoporotic. It's hormonal, but also the wear and tear in women's joints seems to be a bit worse than in men's. So it very well could be some form of arthritis. Now, usually if you can take anti-inflammatories, the ibuprofens, and it doesn't give you stomach problems, then Often that's the best pain relief. Paracetamol will not help. Sometimes massage and movement helps. One of the things about arthritis is it's very often worse when you keep still. So lying on your back at night in bed may aggravate it because it gets stiff. And this is very often a problem with arthritis. So sometimes it's a stiffness that happens. Some of the older partners, siblings, whatever among you may know that, you know, you can be sitting down for an hour and you get up and you're as stiff as a board, or you wake up in the morning, you try and get out of bed and you literally have to sort of crank yourself straight. And that's just arthritic pain and stiffness, that it's quite common. Having pain at night in bed may be asymmetry, and it may well be that you need some positioning equipment, cushions, pillows, specific things to help to relieve some of the pressure.
Okay. Next question is, my daughter has SMA type 2. She has significant pain in her left hip, and it's worse at night when she goes to sleep on her side. We believe it's caused by her spinal rod pushing in her hip. Currently, she's started treatment with cortisone injections every 6 weeks to relieve the pain. She's just started to get back now about 5 weeks. They've added it's a sublux hip.
The rod itself would not be pushing into a hip. The rods are at the back and the hip joints are very much down and laterally. If you go back to the picture of the pelvis, I don't know if you can find it, Marnie, but it's highly, highly unlikely. I think it's right at the beginning, the picture of the pelvis. It's almost the second or third slide in. But for the back, ooh, where's it gone? Let's go, that one. So if you think that the rods are right at the back, where those two little bits of bone are sticking up, you can see how far away they are from the hip joints. There's absolutely no way that having spinal surgery could have poked the rods into the hip joints themselves. That would not be possible. There is no way that any surgeon could have made that mistake. It's just seriously not possible, because they open you up at your back and your hips are very much lateral and to the front, as you can see from that picture. So your hips aren't somewhere where you could have the rods. You certainly can have an arthritic hip, you can have a dislocated hip, you can have an inflamed hip, you can get, if you look at the thing where the joint is open, that labrum, which is the lip, you can get pinching, you can get swelling, you get fluid in the hip, which can actually be too much, and that's inflammation, or you can have too little and then it all dries up. So there is definitely inflammatory processes, there's arthritic processes. If they're doing steroid injections, it sounds as though they think there's an inflammatory process going on, but it may be that in the long term, she does need some surgery to relieve whatever it is that's causing the pain, because there's only so long that you can keep having steroid injections, to be honest.
Okay. Hi, Marion. My son might have to have his pelvis fixed to his spinal rod. Do you know many that have had this? The person who's asking, their son is an adult. He's previously had spinal surgery and are now looking at having to fix.
Yeah, it's not unusual for surgeons who have gone only to what they call L3, L4. Let's have a look if we've got a slide. Let me see which slide would show that. Not quite that one, Marnie. I think the one of the scoliosis with the guy sitting a bit asymmetrically further down, and that's not this one. So in this one, what you will see is that it's usual to rod all the way into the pelvis, which is that sacrum at the bottom. So it's normal in most people, but they may stop a couple of segments up, so that they may stop around L3 or L4, and that is common in type 3. to allow you, and a good type 2, and that is to allow you to keep mobilizing either with CAFOs or independently. So an ambulant type 3 who's having spinal surgery, they will not rod all the way into the pelvis, because those of you who know type 3s who walk, they do tend to have this, what we call lateral sway, and that's to help them bring their legs through. So because of the pelvic power and where the muscles are weak and where they're strong, they tend to sway side to side rather than stand upright and bring their legs through. So it's usual not to go into the pelvis in an ambulant type 3 or a very good type 2 who walks in CAFOs. But it's not unheard of. And I do know people who have had later surgery that then fixes them all the way down into the pelvis, either because the pelvis, because the spine is continuing to tip, or because there's wear and tear. Now, if you imagine your lumbar spine is extremely mobile, but if you fix 3 or 4 segments and just leave a couple of the bottom, you can get wear and tear there, because instead of the movement being the whole length of the lumbar spine, it's concentrated at the bottom, and that can cause pain, problems, arthritis, and narrowing of the space between the bones. And if you get narrowing, that can impinge on the nerves and can cause pain. So it's not unheard of to extend the rods into the pelvis for some people who've had spinal surgery in the past, particularly if they've got problems, and that can be done, yes.
Okay. What stretches would you recommend for hip dysplasia?
The thing about stretches is hip dysplasia is the bone. Stretches are the muscles as well as the joints. We have to think when we're stretching, we're trying to maintain the length of the muscles as well as keep the joints moving. Stretches are not about moving joints. Joints will move wherever they can. But if a muscle gets really tight, if you imagine the muscle at the front of your hip is short and you cannot get your leg right back, and we know a lot of people like that, the muscle here is short and prevents the leg going straight. We are stretching muscle, we're not stretching bone, we're moving the joint. But this is not about stretching joints. This is about stretching the muscle to allow the joint to move as much as possible. People have got this idea that at the hips, for some reason, we're stretching the joint. We're stretching the muscles that prevent the joint moving, all those wonderful movements that it can do. You look at a ballerina, go and we'll put YouTube on and just see how much movement some of these people have at their hips, out to the side, up in the air. Now, I know that's extreme, but that is how a lot of hips move. All those ranges that you can't do because of weakness and because of tightness. So when we're stretching, doesn't matter if they're dysplastic, doesn't matter if they're dislocated. In fact, more so, we're stretching the muscle over the joint. If you're very tight, it can actually help to pull the joint further out of alignment. We need to keep the muscles as long as possible to allow the movement, to allow the hips to be in joint, to stop deterioration and making things worse. It's about stretching muscle first and foremost. Other things will get stretched, but stretches are about stretching muscle that is shortening for whatever reason.
Okay. Mark just commented when we were on this slide, that slide about how he used to be tortured in these as a kid, and then posted a photo of the Shrewsbury splints, which look like they're made of metal. I don't know whether you remember those, Marion, at all.
Probably. I've been around long enough. I probably had them all once upon a time.
Okay, someone else has asked about if a hip's dislocated, what are the solutions?
Well, there isn't a solution. The only solution is surgery, and that depends on whether it's the right solution. The question is, what problem is the dislocated hip causing? Now, if you're expecting to be, if you've got a type borderline type 1, 2, a good type 2, a child who's on some treatment, and you're expecting them to walk and walk independently, effectively into adulthood, and they have a dislocated hip, it's going to totally get in the way. And yes, of course, you're going to want something done about it. You wouldn't want a normal child to be wandering around with a dislocated hip. It will lead to arthritis in adulthood. Don't think for 1 minute you can't walk on dislocated hips. When I was training as a physio, and that's before most of you were born, it was very normal to walk around on dislocated hips. We didn't have hip ultrasounds. We didn't have somebody checking every newborn baby to make sure their hips were in. It became obvious once the child started walking. And not all parents wanted their children to have surgery at that point in time. Anesthetics weren't as good as they are now. You know, there was a big, big risk to putting hips back 40, 50 years ago and beyond. So it wasn't that common to relocate hips for an ambulant child. They just used to walk with this, what we used to call a sailor's gait, a Trendelenburg, and many of them were left until they were arthritic, and then they had hip replacements as adults rather than having anything done to their hips as children. They would just have total hip replacements as adults. And in those days, they didn't only replace the head of the femur, they also replaced the whole acetabulum, and you had a whole hip joint, and they can still do that. One of the big problems with false hip joints, they can do it in SMA and they can do it for pain, but you've got to have decent bone. If your femurs are thin, you can't put a metal piece into that femur because it'll just smash through the bone. And that sounds dramatic, but that's actually true. So you've got to think bone health as well in terms of what surgery they're going to do. They can't just do lots of bone surgery if your bones are thin. So you need your regular DEXA scans, you need your vitamin D, you need to be listening to what people tell you about bone health. It's really important if you've got problems. But in terms of what you do with a dislocated hip, it's a case of what you want it back in place for. And you have to know what you want it back in place for before you decide whether you want it operated on, because no other treatment is going to put that hip back.
Okay. Someone's asked how to strengthen the quadricep muscles, 22-month-old SMA type 2 on treatment.
It's actually really difficult because it's a lot of kicking stuff. So it's lots of doing this. So lots of work in water, lots of work in the bath, lots of work in the hot tub, in the pool. So lots of kicking stuff, lots of standing. Standing is a brilliant one for quads because you've got to keep your knees straight. If the child's on treatment, are they in CAFOs? Are they in gaiters? Are they doing any independent standing? Standing. All my GOS families, all my ex-Hammersmith families know I'm just 100% keen on kids standing, whatever, because that is, to me, the most effective position for doing any strengthening in the right position. This is the position that will strengthen our muscles where we want them to be. This is the position that will stretch the muscles where we want them to be. So I'm a big advocate of standing. Now, I know there are many families out there saying, well, we stood religiously and they still got tight. I know that. But just think how much tighter they would have been if you'd never stood. I know that sometimes you feel as though you're losing the battle, that whatever you do, they still get tighter and tighter. And that is true. But we have to think, if we never treated them, if we'd never stood, if we'd never used all these orthoses, how much tighter they would be. And that makes rolling in bed impossible. And think again, with the new treatments, the adults on the Risdiplam, how many of you got really, really tight hips and knees, where you basically don't even think about what you can do with your legs, you think about what you can do with your arms. But if you've got a 22-month-old, you should be under a muscle center and you should have a local physio. Well, you're supposed to have a local physio. It doesn't mean to say you will, but hopefully have a local physio who can work on quads exercises with you. Lots of great fun, lots of kicking, lots of splashing, lots of swimming, all sorts of things you can be doing for quads. And if you really can't find anybody, message me and I can send you lots of nice ideas for quads, even at 22 months.
Okay, we've got another question saying, my daughter had scoliosis and put a lot of pressure on her hip. She hasn't had any problems, and they added further down that she had corrective spine surgery years ago, which is why she hadn't had any problems. But recently, when she goes from a sitting position to a laying down position, it is very sore and hurts. Is there any exercises she can do to make her hips looser?
I'm not 100% sure what the problem is going from lying to sitting. It sounds to me like it's probably pulling. So that if she's gone from sitting and she's gone to lying, did you say she's had spinal surgery?
She has, yeah.
Okay, so what's happening is you've got tight hamstrings, probably, you've got tight hip flexors, you're lying down, there's no arch in your back. So basically what's happening as you go back is your legs want to go up in the air, your knees want to get bent. And so everything is changing position, everything's trying to stretch out. Now, when your legs want to go up in the air, that's fine, but the effect of gravity then wants to pull them down. So when you lie down, just in a normal situation, you don't lie down and do that. You don't actually lie down plonk like that. You lie down like that. But if you think that you're tight here and you've got hip flexion contractures, even if they're not 90 degrees, even if they're only 45, as you go down, your legs want to pull up in the air. Gravity's going to pull them down. So you're going to get some problem of your back going down, your legs wanting to come up, but gravity pulling them down. So you will get a bit sore and achy. So lying down can be a problem if you're quite stiff. So you have to think you've got no flexibility in your spine. Everything's happening from your hips, so it can get quite sore. So that, again, make sure we're getting our stretches in. Think about how you lie down. It may be that you don't go down straight backwards, that you go down sideways, you roll into a sideways position, or you sit over the edge of a bed, go down sideways, and then have your legs brought round afterwards. So it may be just changing the way you go from lying, that you don't go from just straight backwards. But as I say, you come from a sitting position, sitting over the edge of the bed, go sideways and legs around, or you just have to take those legs up, go backwards, so that you end up bringing the legs up to go back and then trying to bring the legs down as they would go. But it is a case of tightness that's causing the problem. And it's strange because children who lie on their side who have very tight ITBs can often get, or even adults can get pain here, because what's happening is the tight ITB wants to pull the leg up in the air, gravity wants to pull it down, and you get this aching across the top of your hip. What you really need is pillows or a cushion in here to support the top leg. And very often hear of people aching here when they sleep on their sides. Now, a lot of BiPAP users do sleep on their back, and that what may need to happen, and a lot of people object to it, but it may be the only way to keep you comfortable, is to have a roll or a long cushion or a bolster or something under your knees to take some of the pressure off your hips or your back.
Okay. We've got...
Marion, you asked me a question before we came in.
Yes.
Have you asked me that one?
No, I haven't yet. Do you want me to ask you that one now? Because it is about pain.
Yeah.
The bleeds on. Okay, I'll just find it. 1 second. Okay. My 12-year-old daughter has SMA 3/2. She had spinal surgery last June, and as her scoliosis curve was over 100%. Her back is now much straighter, and her surgeon says her pelvis is straight, but she still sits with her right hip tilted slightly up and out, as she always did before surgery, just now not as pronounced. She wakes through the night with pain in her leg, which I think originated from her hip. She does exercises daily in school. She is currently not using a standing frame, although we are trying to get her back in it. She is either in her chair or her bed. When she sits in her bed, her left leg bends out slightly. What more can I do to reduce her pain?
Well, I think one of the things in bed at night is, although she's straighter, and obviously a 100-degree curve is a very, very big curve, which is much straighter, so that her pelvis will be more level when she's sitting, but not 100%. So that presumably before surgery, she was very much over to one side. She hardly sat on one bum cheek, so she was virtually all on the other bum cheek. They've straightened her up. Her pelvis was all nice and level, but her hip is not used to the pressure of actually sitting on it. And this very, very often happens. We're nice and symmetrical, everything's been straightened up, weight going through both hips, but we're not used to weight going through both hips. That wasn't what happened for such a long time. She was 12 when she had surgery. She hadn't sat through that hip properly for a while. So that is going to ache a bit. Her leg is rolling out. The tightness won't have gone. Whatever tightness she had at the pelvis won't have gone. So the fact that she's sitting more symmetrically doesn't change the muscle tightness that she had, unless they did muscle releases. Now that's going to be unusual, because no spinal surgeon's going to go into the spine and then suddenly do the hips. So that the tightness is still there, but she's sitting differently. Obviously that tightness is now pulling that left leg out to the side. Because if you think about it, she was probably sitting mostly on her left leg, and you didn't notice the right one stuck in the air. When you bring them back, the left one's gone out. And you didn't notice it before because she was more on that leg, and that leg was more anchored. Now she's on both legs, that leg's sticking out. We're back to stretchers. I would be very tempted when she's lying in bed at night again, if she's lying on her back, to try and cushion her to take some of the pressure off her hips. And it may be, if she's lying on her back, one of the ways of getting some of the pressure off her hips is to support her knees or to support under her bottom. It may be that your OT can help with some sort of one of those matched supports might be helpful. It may help her legs from rolling out as well. Something like the E-roll, as long as it comes right up under her bottom, gives her more support than maybe the mattress does. And maybe she could have something custom made that would support those hips better. But while the surgeon says, oh, a pelvis is much straighter, yeah, that's fine. But actually it's changed things quite dramatically in terms of the weight bearing. And that's fine from how it looks, but it's not maybe fine from the way it feels. So that it's easy for the surgeon to say, oh yeah, that's much better than it was, but you have changed the weight bearing, the positioning, and the way that everything happened before, and that's going to take some getting used to. Things are not going to change. You know, as I say, they changed overnight with spinal surgery, but they're not going to go back to where they were, because everything has changed. So we need to adapt, we need to wait, we need to stretch, we need to support and cushion.
Okay, I'm wary of the time. Are you okay to keep going? Or?
Yeah, no, we're fine for time at the moment. We can always add these questions into next time, Marnie, because it's pretty much the same subject, but it's more on the spine.
Yeah, okay. This one, if I say it wrong, I apologise. Will myofascial release have limited...
Oh, myofascial release. Yeah, we talked about this before.
Yeah, have limited effectiveness in optimizing tight hip flexors, and will E-stim help to activate the gluteals for reciprocal inhibition to the tight hip flexors?
Basically, myofascial release won't do anything with a tight piece of muscle. Myofascial release is what they do for nerves when you have nerve pain for whatever reason. It sounds as though myofascial release to relieve the fascia is going to do everything, but actually I'm not convinced about, and the question is a little bit sort of non-related to SMA. It's very much a sort of musculoskeletal type question. Myofascial release is used by some physiotherapists to look at sciatic nerve pain, to look at neck pain, to look at impingement pain. but I'm not sure that myofascial release will just stretch the muscles the way they need to be stretched to relieve some of the problems that are obviously associated with the hips and pelvis.
Okay. I think you've already covered this, but can you walk with hips out of socket?
Absolutely, not a problem at all. It's not the prettiest thing in the world, it's not the most effective thing in the world, but certainly I don't doubt that there are a lot of underdeveloped countries where there are children every day walking around on dislocated hips without any problem at all. The biggest problem, as I say, with dislocated hips in the population and walking around on them is the long-term effect in adulthood and the arthritis of the joints that it causes, or premature arthritis, because most of us who end up fairly old, and particularly women, as I say, will end up with some arthritis in our hips and joints. That's just the way we are. That's the way we're built. We're not supposed to be upright. Even so, we are. Apparently, we're still supposed to go around on all fours. Would be much better for our joints. But I'm not convinced about that. It does hell for your knees. But certainly, there's no problem with going on subluxed joints or dislocated joints. The biggest problem is if one is dislocated and one subluxed, or one subluxed and one's in, is the asymmetry it causes. I used to say that the best cure for one dislocated hip would probably be to dislocate the other one, but nobody would ever take me up on that. But asymmetry is more of a problem than the actual dislocation or subluxation.
Yeah, okay. Will having hips pinned in place correct hip and knee contractures?
No. Basically, it certainly won't touch your knee contractures. It's nothing to do with your knees. Will it correct your hip flexion contractures? Not necessarily. It'll put your hips back into joint, but ultimately what it does to the muscle will depend on how much the surgeon has to cut, how you are positioned post-operatively. If you're stuck in a hip spica-plaster, which is basically from your, if they do both hips, you have plaster from your waist down to your knees, separately, obviously, with a toilet hole. If it's one hip, you will have a half spica, which it goes around your top and there. It may be that they don't do that, that if they put enough metal work in, that you don't have plaster. I think it depends on the age and the size of the person. But as I say, adults, they don't put in plaster. That it's impossible to manage an adult in plaster in a hip spica, but they certainly manage children. But how it affects contractures, no, unless they literally chop a lot of muscle to prevent it all pulling out. But when you chop muscle, when surgeons cut muscle, they can do two different things. They can lengthen muscle, which is stretch it, either by sewing it in a way that makes the tendons longer, or they can do sort of zigzag cuts. There's all sorts of things they can do to lengthen it, or they can transect it, which basically means just chop it. But ultimately, it will still tighten up if it's got muscle imbalance, and even a muscle that's transected, and that's very common in the ankles to do transections, is just literally cut the Achilles tendon. It will still join up again and get tight again.
Okay. If you are never likely to walk, what is the benefit of a hip operation if you are without pain?
Well, actually, we feel the same, and the orthopedic surgeon, we've discussed this. We had a little boy with a really quite weak type 2, who it was highly unlikely was ever going to walk. Both hips are out. He has absolutely no pain. Because both of them are out, he's quite symmetrical, so he sits symmetrically. It's not impacting on his spine. So again, with being a weak type 2, the surgery is a greater risk than the hips being out, and therefore it wasn't felt of any value at all. So that if there's no issues, then it's probably unlikely that hip surgery will be a benefit. But in the States, they seem to be doing lots of surgery. Now, whether that's for the benefit of the surgeon rather than child, we don't know, because as I say, we have not seen a lot of outcomes. And although I asked the group, the professionals, what experience they'd had of hip surgery. Nobody came back, so I can only assume nobody's really doing it that much. But it will be interesting to find out what they're doing in America, because that's the country where people seem to be the most keen to do a lot of surgery. And as I say, the question has to be always, is this for the benefit of the surgeon or the benefit of the child? There are undoubtedly situations where you do need hip surgery, as in severe intractable pain, as in the hips getting in the way of the child progressing in terms of walking or standing, or if they are impacting on the spine and they are the cause of spinal asymmetry. But for hips that are not painful, that are quite symmetrical, for a child or even an adult that isn't going to walk, then you have to really weigh up the value of surgery.
Okay, I'm 18 years old and would like to ask if you had any advice on how to stretch my left hip, which is a bit stuck in the air when I sit on non-cushion surfaces. They've said, sorry if someone's already asked this, but they came late to the webinar.
The problem is really when you're trying to stretch is what positions you can get into, whether you've had your spine fused. If you want your left hip stretched, my honest feeling is, can you show the picture of the 3 stretches for adults, Marnie? Because it would be, if it was your left hip, I would go for the side lying one, that one, the bottom picture, and I would go for that stretch, particularly concentrating on your left hip. It really is a nice stretch for adults. It doesn't or shouldn't impact on the spine. You can stabilize the pelvis by obviously the guy who's holding is really, he doesn't look as though he's holding it very tight, but believe me, in SMA, if you've got an adult, you've got to stop it rolling around, hang on to the pelvis and bring that leg backwards. You do need somebody who can take the weight of the leg, and that is your best stretch for your left hip.
Okay. I think again you've answered this one by answering another one, but can standing with your hips out cause damage?
Well, ultimately, yes, you may end up with arthritic hips, but the question is whether standing would make them worse. Will really depend on whether you feel it's uncomfortable to stand. If you are getting pain when you're standing, then I would suggest that yes, it is possible that it's not the best position. It may well be that you don't need to be standing quite as straight, and this idea that we had where you're a little bit bent at the hips and a little bit bent at the knees, may that sort of slightly concertina effect take some of the pressure off the hips and put them through the knees, but that might be uncomfortable as well. That might encourage your knees to get tighter. If you are standing on dislocated hips and you are getting a lot of aching after you've stood, if you've only stood for about 20 minutes and your hips are really aching after you've stood, then yes, you may have to consider whether what you are standing in is the best option. If you are standing in a standing frame, you may want to consider going to the supine stand, the one where you're lying, so that there isn't quite as much, so that you're not actually standing upright, you're slightly back, supported behind you, because that's what a supine stander does. And it may well be that a supine stander, not quite completely straight, is more comfortable. But I would only worry if you're getting pain or pain and stiffness after a relatively short period of standing.
Do adults with SMA have problems further down the line with hips? Does it lead to the spine or rods twisting?
Shouldn't do, shouldn't make any difference. In the long term, if your spinal rods twist, that's more to do with your spine. I don't think the hips change dramatically. I haven't come across a lot of adults who've needed revision of their spines. But remember, things were very different when they were doing that one-stage operation, and people varied a lot as to whether they had a very rigid spine, whether they had a very flexible spine. The surgeons had very different ways of doing things. If you think, what, 30 years ago, they were doing Luque fusions, which was almost like knitting the spines together. Some people will have Luque fusions. Different rods were in use, different lengths of rods, different Some people even had single rods. The number of screws they used was very different. So there was a lot of different operations going on in those days. So it really, really depends on what operation you had. A Luque fusion was absolutely rigid, and the likelihood of it twisting was pretty remote, but some of the wires could come loose. So there was different problems with different types of surgery. Now it's very much more standard. People have a totally different idea of what works. But again, it will depend on the number of degrees. It also depends on the type of curve you have, because there's lots of different sorts of curves. You can have a curve that is literally C-shaped. You can have a curve that's S-shaped. It's whether the big part of the S is in the chest, the thoracic spine, or whether the big part is in the lumbar spine. Because if it's in the lumbar spine, it's going to have, obviously, if the biggest part of the curve is here, it's going to have more effect than if the biggest part of the curve is up here. So really is very, very variable. You can't say, give an answer that's going to work for everybody.
Yeah, I think it also goes down to just the life in general, like if anything else happens.
Yeah, and also just generally about your growth and how you were, what stretches you did, what standing you did, all the different things. I think we're going to have to leave it there, Marnie, because you may have heard the dog's getting ready for his walk. He's getting a bit miffed with me because we haven't been out. So I think I'm being told that it's time to take the dog out.
Yeah, well, thank you as always, Marion, and
we will continue when we do the spine. So if there were questions I didn't answer, I will answer them next time, Marnie.
Okay, great. Thank you, Marion.
No problem. See you in 2 weeks. Thanks a million, Marnie.
Bye.
Take